management is not a psychotherapy, and it's atheoretical, and that's something that's a little bit different from dialectical behavioral therapy, which has very strong roots in behavioral therapies and behaviorism. And it's really, dialectical behavioral therapy is really guided by a set of theories that the clinician uses and a set of protocols that a clinician uses, whereas because of its atheoretical nature and its heavy emphasis on pragmatism, GPM is a treatment, not a psychotherapy, that's maybe a little bit more easily adaptable to a variety of different contexts and situations. It's a treatment that a person could learn, in maybe 8 or 9 hours, as opposed to having to go to long, week-long seminars or multiple week-long seminars. And the results that we're seeing from good psychiatric management, or GPM as we call it, are just as good as the results from what has been up to this point considered the gold standard treatment for borderline personality disorder, and that's dialectical behavioral therapy. The things that really set this treatment apart is a heavy emphasis on diagnostic disclosure, providing psychoeducation, giving a patient a sense of hope about the prognosis of borderline personality disorder. One of the things that we know from longitudinal studies is that the vast majority of people with borderline personality disorder, upwards of 70%, even if they don't receive any treatment, will recover from borderline personality disorder, but might have some residual functional impairment. So the treatment, good psychiatric management, helps someone to get to a point of remission earlier, but also helps to improve their functional status. And it does this through a heavy emphasis on accountability and change, a reduction in unnecessary psychopharmacology or polypharmacy, which can sometimes be harmful to patients over the course of years. And also some of the other tenets are being relatable to the patient and being pragmatic about the kinds of interventions that you implement. The other thing is that we tend to take a much more active stance in this model of treatment. This isn't a treatment where we sort of sit back and listen and be quiet and like some of the older forms of psychotherapy. This is really a kind of treatment that pulls from principles of both a psychodynamic approach and also from a behavioral approach. And that's what makes it really flexible and unique. One of the areas where GPM is particularly good are in people that have a high degree of comorbidity, because it helps us to prioritize the treatment, and it helps us to get a better sense of risk assessment. Oftentimes patients who have borderline personality disorder are sort of, reflexively or repeatedly hospitalized in a way that really removes them from their life. And the emphasis on our treatment is really moving forward with building a life outside of treatment, because that's the thing that's going to help a person develop more of a sense of identity, more of a sense of self-esteem, and will help them to find some area in their life where they feel like they have more meaning and purpose that can help them weather the difficulties that they may have in relationships, work before love, and life outside of treatment. And these are the two things that we come back to time and time again with the patients that we treat. It's not that we don't take their desire for attachments or for relationships serious, but we want them to be more successful, and in order to do that, they have to have a steady stream of self-esteem that's coming in through some contribution to society, and we really aim to help be with them and coach them to get to that point. We try to be non-reactive, thoughtful, and steady in the treatments of these patients. For example, when a patient tells you that they're suicidal or they're having high urges to self-harm, somebody in a GPM model treatment would have already done a pretty thorough risk assessment. They have a model of thinking about the patient that helps guide and better predict risk when there's more imminent and acute risk in this population where there's a chronically elevated risk. And in addition to that, oftentimes what we'll do is be curious, because for many people with BPD, self-injury or expressions of suicidality is the best way that they know how to communicate the amount of distress that they're in. And we want to be very careful to not overreact and start doing things, or putting them in the hospital, involuntarily committing them, taking them out of their life, until we have a good risk assessment and we've parsed out whether or not what they are saying is a communication of distress, and something that we can manage by enhancing the relationship through things like validation, curiosity, and understanding of that person's experience. For the vast majority of people, good psychiatric management is good enough for them. Once a week, 1 hour, or sometimes even 30-minute appointments, continuing to focus on functional status, building a life outside of treatment, for the vast majority of people can help them get to a place where they're functioning better and they're feeling subjectively better. For those people that aren't able to, over a period of 3 or 6 months, start to improve, and in the handbook for good psychiatric management, there are markers for how to assess whether or not somebody is improving with the treatment that's being delivered to them. At that point in time, in a stepped model of care, we would look to start to increase the level of support that a person's getting, and maybe go to one of the other evidence-based psychotherapies that has more hours per week of treatment. Good psychiatric management right now is in its early stages of being disseminated out and being taught to clinicians. There are conferences that are available, often at low cost or sometimes even free, that my colleagues at McLean Hospital, through the Borderline Personality Disorder Training Institute, host at least several times per year.